occasionally as young as 18, but I will see some women in their 20s and 30s. And then I see a lot of women in their 40s, 50s, 60s, 70s, and 80s, and I have a few in their 90s. A lot of these issues, which are common to me, urinary incontinence, leaking, pelvic organ prolapse, recurrent urinary tract infections, microscopic amounts of blood in the urine, are really common, in particular after menopause. And so a lot of the women I treat are postmenopausal, although not exclusively. And we go all the way through. Some of my younger patients are surprised to learn that some of these problems are not uncommon in younger patients. And some of my older patients are surprised to learn that there's still something to be done when they've been told for many decades that this is just a sort of normal part of getting older. And so I'm always sort of disheartened when I help somebody who could have been helped 10 or even 20 or more years ago. So my breakdown, I probably see about 70% urogynecology and 30% regular GYN patients. And among those, it's a pretty even split between my patients with urinary leakage, with pelvic organ prolapse, which is a medical term for the vagina falling down, and there are different ways in which the vagina can fall down. A few patients with postmenopausal bleeding, a smattering of patients with blood in the urine.
All right. So, it's interesting when you say that, like, a lot of people think that they just have to live with this. And I think, as physicians in general, and definitely surgeons, we see this a lot. And so it kind of brings up the first myth that we want to talk about, which is, that leaking urine is normal as you get older. And everybody kind of hears that, or, moms will all joke about jumping on the trampoline and you can't really do that anymore. I can't do jumping jacks. So, it's interesting how maybe because we talk about it or because the techniques are older, I don't know. So it's a great topic to talk about. So I'll just let you kind of start on what people need to think about if they do have leaking urine, and what's normal and what's not, and what the options are for treatment.
Yeah. So while it's true that it's more common for women to leak urine as they get older, I would never say that it's a, quote, normal part of aging. I often will say to my patients, just to kind of show the bias, a normal part of aging is getting gray hair. That's a normal part of aging. And we could do something about it, or we don't need to do something about it, but that's what we think of as a normal part of aging. Something that's a medical problem that's really common with aging is like getting cataracts in your eyes. And we would never say to a patient, oh, you can't see very well. Oh, well, it's a normal part of aging. Oh, well, because that's almost like a laughable example, but it's really around the stigma that we don't like to talk about gynecologic or urologic issues. We don't want to admit that we leak a little here or there. And we don't think there's a whole lot that we can do about it. Oftentimes, primary care physicians don't know what the options are to treat it. And so they don't want to ask, because if they screen patients and then they can't offer them a treatment, they feel badly about that.
Hey, honey, how are you? Good day?
Somebody needs to mute.
And so I commonly will tell patients, yes, it's common as we get older to have these problems, but it's still considered a medical condition. It is covered by insurance as a medical condition. This is not a question of vanity. And I find that my younger patients are often more accustomed. They've been raised in such a way as to know that this is unacceptable. And sometimes my patients who were part of the silent generation are more likely to have been told that they need to be stoic about these things. And that's not my attitude as somebody who is able to treat these. I can't always treat the condition such that somebody is dry and never has a leak again, but we can always pretty much get people to a significant quality of life improvement.
That's awesome. And what are the causes for this? Is this always related to childbirth? Is it sometimes just age and someone who's never had children? And, I think it's probably helpful for people to know what the range is. Like, what is that leaking? Is it sneezing? Is it trampoline? What's that range of symptoms?
Yeah, so one of the common myths is I think that when people think of my underwear are getting wet or I need to wear a pad, they think of that as automatically a bladder problem. And what's a bladder problem is what we call urgency related leakage. So I have to go so badly that I can't make it to the bathroom in time. That is a bladder problem. And that is a type of urinary leakage that is more common after menopause, although I have seen women younger than menopause who have it. And that comes from the bladder muscle, this muscle that surrounds our bladder called the detrusor muscle, which is really supposed to be relaxed most of the time. It's just hanging out until we need to go to the bathroom. We sit down on the toilet and our detrusor muscle squeezes and pushes the urine out. And that's how our bladders are supposed to work. When that bladder muscle squeezes or spasms without permission from our brain, then it gives us the sense of, I need to go and I need to go right now. And if we don't make it to the bathroom in time, we get wet. That's a kind of different problem than what Dr. Grunwald was just talking about, the trampolining, the coughing, the laughing, the sneezing, exercise. That is called stress incontinence or activity-related leakage. We usually don't like the term stress as much because it makes it sound like it's a psychological problem when it's really not. It's an issue not with the bladder itself, but with the tube that drains our bladder, our urethra, the tube that we pee through. And in fact, pretty much everybody, if they're about to cough or sneeze or jump, they're going to clench those muscles. And after childbearing, it's more common for that clench to just not keep us dry. And so when I see a patient who complains of leaking, I try my best to take a detailed history so that I can really figure out, does she have a bladder problem or a urethra problem or both, because the treatment options are different.
Interesting. So I do have a question in the chat box, which is something about intrinsic sphincter deficiency. It's a big, long word. How is that different than stress incontinence?
Well, I'm going to reveal our question asker as a urologist. So don't feel badly if you don't know as many big, long words as she does. So intrinsic sphincter deficiency is really so we all know, especially those of us who came to Dr. Childs' talk last week, we all know that there's a sphincter around our anus, and that sphincter's job is to keep our poop in. Much less commonly known by people who are not in medicine is that there's a sphincter around our urethra too, whose job is to keep our pee in. And if that sphincter is not closed tightly enough and our urethra is kind of open all the time, then that causes a particularly severe form of activity-related incontinence. And so even with just maybe stepping off a curb or standing up or not doing much of anything, walking around, women can leak very, very easily. And so that is typically treated in the same way that normal garden variety activity-related leakage is treated, but is just a more severe form and might be slightly more difficult to treat.
Excellent. So can you talk about, is this only a surgically treated issue? Are there non-surgical treatments? And does someone always need to come see you? Can their primary care doctor treat some of these? What's that kind of course, and what are the surgical and non-surgical options?
Yeah, so for the activity-related leakage, which is common in both younger women and in older women, oftentimes because this is an anatomic problem, it's not treated with medication. So it can be treated with non-surgical options, pelvic floor physical therapy, which a lot of women who are surprised to learn that there's such a thing as urogynecology may be even more surprised to learn that there are physical therapists who focus on the muscles around our bladder and our vagina. And a lot of women think of pelvic floor physical therapy as Kegel exercises. There's more to it than that. Sometimes it's almost like having a physical trainer, a personal trainer for your vagina or your bladder. That can be helpful. There's also a device that can go inside the vagina to put pressure on the urethra from behind and extra support to that urethra. So that then when you do cough or laugh or exercise in particular, it helps hold the urine in. There's a device that's sold over the counter or online called the Poise Impressa, IMPRESSA. And that comes in with a sizing kit, small, medium, and large. And it's essentially like an industrial strength tampon. And it's a one-use kind of thing. And then it's really based on a medical device called a pessary, which some of my older patients who are accustomed to using a diaphragm during their reproductive years might remember. Some of my younger patients luckily didn't have to deal with diaphragms. But that's a device that's made out of a soft medical grade silicone that's flexible and bendable and can be put inside the vagina and sort of opens up inside and also can compress the urethra so that women don't leak. The surgical options are things like a bulking injection, which can be done in the office, which is nice for patients who want to avoid going to the operating room. And that's not a medication, it's really a filler. So kind of like people who get collagen injected into their lips so they have nice plump lips. There's something that can be injected into the vagina, into the urethra, so that women are essentially peeing through a narrower tube and are less likely to leak. The gold standard is a surgery that takes me about a half an hour. It's done as an outpatient, so women go home on their own the same day. It's called a midurethral sling. So that is not the quote evil mesh that you might have heard or read about. This is a different procedure. It's been around since the early to mid 1990s. And it has a pretty good, about 85% success rate at treating activity-related leakage. All of those things are in a separate bucket than the options to treat urgency-related leakage, which can involve pelvic floor physical therapy. That's the kind of thing where people tell you, don't drink so much coffee or other caffeinated beverages, making sure women are normalizing the amount of fluid they're drinking, somewhere between 30 and 64 ounces a day. Sometimes, particularly in Los Angeles, we're very health conscious and women are drinking well in excess of 64 ounces a day. And then if they have working kidneys, what goes in must come out. Sometimes overactive bladder or urgency related leakage can be treated with medications. And there are really two categories of medications that are used to be treating those. And sometimes there are primary care physicians who feel comfortable prescribing those medications. And so it doesn't require referral to me. There are also more advanced therapies, and there are 3 that are currently FDA approved, some of which are surgical, some of which are not, that are often used for women who don't respond well enough to medications and still have urgency or frequency waking up in the middle of the night despite medications.
So I have a question that I'm going to get to in a minute, which is about if you can't empty your bladder. But in talking about leaking and those, and you talked about some non-surgical and medication, and is that always approached in kind of a step fashion where you start with kind of the non-surgical approaches first or the medication approaches first, or sometimes is it like, no, you just need surgery? And how does that usually go? Do you usually see them through this? Or sometimes is some of that managed by their primary care to see if that works, and then they come to you as a specialist?
So I've seen it both ways. So sometimes patients will be attempted to be managed by their primary care or their regular gynecologist or their regular urologist, and they've already tried a lot of things by the time they get to me, and it's clear that they need more advanced management. Sometimes patients come to me and they say, I'm not interested in being on a medication. Can we just skip this step? And the answer is, as long as you're counseled properly and you understand that medication is an option, I do not make people jump through any particular hoops in order to get to the intervention of their choice. But if a patient comes to me and they really haven't been treated in the past, I kind of lay out all of the different options that are available, and I say, let's start at the beginning. And then always kind of making sure that they have a time when they know they're going to follow up with me, let me know how well their intervention has worked. And then it's really, because this is a quality of life condition, the patient's choice as to whether they need something more aggressive, they want to escalate, or if they're comfortable with the frequency or the how many times they're waking up in the middle of the night. Usually patients who are wet are not happy. But once patients are dry, I have patients who say, I'm peeing 8 times a day and it's driving me crazy. And I have other patients who say, I'm peeing 12 times a day and it's so much better because I used to be peeing 20 times a day. I'm so happy where I'm at. And I think medicine has evolved in the last, particularly 10 years, but even more than that, such that we're not trying to reach a number that's determined by the medical establishment. We're trying to reach a number that's in keeping with the patient's goals.
Yeah, that's great. Super helpful. So I'm going to ask this question that's in the chat, which is, what about women who struggle to empty their bladders properly? And maybe as you answer that, you could talk about the workup, because I think some people, here you go in, you got to do these tests. They're kind of weird. They're you got to like pee on a paper or standing up or whatever those are. And so, so about the women who struggle to empty their bladders properly, and then kind of what are some of the workup tests that you do?
Yeah. So there are many different reasons that somebody who feels like they're not emptying their bladder properly may or may not be emptying their bladder properly. So one of the things that when patients tell me I don't think I'm emptying my bladder well, is for me to actually check and say, okay, pee, and then I'll check either with a quick in and out catheter, or with an ultrasound on the belly, to see how much urine you have left in your bladder after you go. Because there are women who feel like they're not emptying their bladders well, and they are really emptying their bladders fine. And the question is, why do they then feel like they're not emptying their bladders properly? Or women who are truly not emptying their bladders properly, and then having a quantitative measurement of to what degree that is the case. How much urine are we talking about? If it's a lot, then we get worried that they're not emptying their bladder and the urine is actually backing up into their kidneys and can cause the kidneys to swell. That's sort of the worst case scenario. There are a lot of women whom I see with prolapse. The vagina is falling down, particularly the front wall of the vagina, which also happens to be the back wall of the bladder. And turns out when the bladder is falling into the vagina, it makes it difficult to pee, because typically the urethra, or the exit, the off ramp, if you are a little bit of urine, should be at the bottom of your bladder. That's how the urine comes out easily. But if the vagina is falling down and bringing the back part of the bladder down with it, then the urine almost has to go up and over the mountain in order to get to the exit. And so I see women with prolapse often who might not be able to empty their bladders well. There are also women with a number of neurological issues, be it MS or Parkinson's, other things that might make it difficult for their brain to tell their bladder to empty now. So trying to figure out the cause is important before we can resolve that issue.
A really good reason to see a urogynecologist. So I think you talked about this a little bit, but what about the in-control devices that patients can buy at home? So you talked about one of those. What are the others of those, and do those usually come, like, do you sometimes suggest those to patients to try?
Yeah, so the Poise Impressa is the common that's the one that I liken to an industrial strength tampon. And you can buy it on Amazon, you can buy it at your local pharmacy. And it comes with a sizing kit, so that you know if you're a small, medium, or large. And then once you know your size, you can buy only that size. The nice thing about that is for patients who either don't have good access to the medical system or are just so embarrassed about the possibility of talking to somebody about this, or are live far from a urogynecologist. There are not that many of us. It's nice to have something that's more accessible. I don't think that the Poise Impressa is any better than a pessary is in terms of controlling activity-related leakage. There is one bladder medication for urgency, frequency, urgency-related leakage that is common and available over the counter, and that's called the Oxytrol patch. I do not recommend it because I think that the prescription medications have fewer side effects, and the Oxytrol patch is more likely to have side effects. So I typically don't recommend that to patients, but it is available without a prescription over the counter.
Awesome. So keep your questions coming in the chat and we'll kind of go through them. The next question kind of leads us into our third myth that we're talking about, which is moving into the vagina. There's nothing that can be done if the vagina falls down. And, you know, it's funny when you hear people talk about things and they're like, and her vagina was completely coming out. And what is that? So the question in the chat box is, are there any other symptoms of a prolapsed vagina? And so maybe you can, since prolapse is not a word that most people know or use frequently, maybe you can explain what that is, and then what that is, like when people say, like, and my vagina was falling out.
So prolapse just means coming through. So, you know, one of the most common ways that people will hear prolapse in a medical setting is mitral valve prolapse, which is in the heart, which is the heart valve coming through when it shouldn't be. A prolapsed vagina is the vagina coming through the opening when it shouldn't be. And rectal prolapse is the rectum coming through the anus when it shouldn't be. So coming through when it shouldn't be is kind of the common lay term for prolapse. And really, prolapse is typically not painful, which is sometimes why it takes patients so long to get to me. Women have a tendency to put many things ahead of their own needs on the priority list. So I have my job, I have my kids, I have my aging parents, I have, you know, the dog needs to go to the vet, and I have, you know, to exercise, and I need to meditate, and I need to, you know, I have to do all these things. I haven't checked in with my friend in a long time. And we tend to be like, oh yeah, and my vagina's been falling down for 10 years. I should probably get to that at some point in time. Most people with a prolapse in their vagina feel a sense of bulge or a sense of fullness, a feeling like I kept a tampon in for too long and there's just something there that shouldn't be. Sometimes people will say that they're washing in the shower and they'll feel that there's something there, there's tissue there. Sometimes if it's really far down, patients will be concerned. They'll come to me and they'll say, is this going to detach from my body? Is my uterus going to, am I going to see it in the toilet? Is my bladder going to, am I going to see it on the floor? And the answer is no, it will never completely detach from your body, but it can sink lower and lower. And oftentimes it sinks lower after a long day on your feet, after heavy lifting. So sometimes when I see patients at 8:15 in the morning and they say, no, really, it falls down, I say, I believe you. If you were here at 8:15 at night, I would see this coming down further. And so sometimes I'll have patients come back in the afternoon when I can measure the amount of vaginal prolapse better, because we know that it's not necessarily consistent. Patients will have good days and they'll have bad days. They'll have times of the day when it feels worse. Another myth is patients are saying, I'm afraid to have sex with my prolapse. And really, if anything, if it's using the vagina for sex, that's oftentimes pushing the vagina back in. Sex isn't going to make prolapse worse. It's also not going to make prolapse better. I have had my patients with male partners are often very quick to tell me, oh, but I can push it back in. Thank you very much, sir. So we know that sex is not dangerous for prolapse. Really, the biggest culprits for prolapse are babies, especially babies who came out vaginally, especially babies who were big when they came out vaginally or who came out with forceps. So, I tell my patients if they have children that I hope they're kind to you on Mother's Day and every other day. But I have seen prolapse in women who have never had a pregnancy. So having a C-section is not guaranteed to save you. Not having a pregnancy is not guaranteed to save you. Like any medical condition, none of us can escape our genetics. And if your mother or your sister or your grandmother had prolapse, depending on what generation they were, they probably weren't telling you about it or telling anybody else about it. But our genetics follow us. And so some of us are just stretchier. And this is a condition that's really caused primarily by gravity. So when I treat this, there's always a chance of the prolapse falling back down again. The surgeries or the pessaries, which are the primary treatment options, are usually pretty good at keeping the vagina lifted and the symptoms treated. But I tell my patients that unless they're going to go live on the International Space Station, that gravity is unkind to us all. So,
yeah, that is that is the truth. No one told you that when you were young.
As a breast surgeon, you know about gravity being unkind to us, right?
Gravity's so unkind.
There you go.
The bigger the breasts are, and I use the same space station thing. Like, if you're not going to live on the space station, you wear a bra.
There you go.
So as things fall out from gravity, there are the non-surgical option. It sounds like is a pessary. And then is the only other option surgery, and how does that work, and what things can fall out of the vagina?
So when I talk to patients about prolapse, I talk to them about really 3 different ways of proceeding. One is just kind of a wait and see approach. And we say that that's an option because the vast majority of cases, prolapse is not dangerous. You're not going to land yourself in the hospital for failure to treat your prolapse. And in particular, patients who say, I'm really not bothered by this. I was told by my gynecologist that I have this, but I wouldn't know it's there unless my doctor told me about it. Those people typically don't need treatment. It's good for them to establish care with me because then if it gets worse, they're already plugged into the system. But it's not something that requires treatment. And I often say to patients, if you're not having a problem, I can only make you the same or worse. I can't make you better. A lot of my patients, however, are bothered by their prolapse. Even if it's not painful, they're bothered by it. And so I really talk to them about pessary versus surgery. A lot of people think that Kegels or pelvic floor physical therapy is going to help them. And while it may have, maybe have some role in prevention, it does not really have any role in treatment of prolapse. So I tell patients, sometimes they'll come to me after 5 years of kegling their heart out and say, this just hasn't worked. And I say, you can't kegel your way out of this because it's really not a muscle strength problem. It's a tissue stretching problem. And so a pessary, different shape than the kind that we use for activity-related leakage, but a pessary is used in the vagina to help hold things up. And I liken that often to contact lenses. I'm not wearing mine right now, but for the last, 30 years, I have had poor vision. I have never gotten it surgically corrected. Every day I put on my glasses or my contacts. Yes, I notice them going in and coming out. But for the most part, I walk through the world not bothered by my medical condition and not even noticing that there's something on my face or in my eye. And yes, there are patients who can't wear contact lenses. They think it's icky to put something in their eyeball. That's what a pessary is like. There's some patients who are like, I don't like that. And those are the patients who would warrant surgery. And there's some patients who say, who have a vagina that's not the right shape to hold a pessary. The pessary keeps falling out. And so I don't make people try a pessary before they have surgery, but I make people understand that pessary is a treatment option before they have surgery. And there are many different surgical ways to treat prolapse, depending on what part of the vagina is falling down. And urogynecologists usually think of there as being 3 different compartments in the vagina. So the front part of our vagina, which is the back wall of the bladder, the top of our vagina, which is either the cervix and the uterus, or if we've had a hysterectomy, what we call the apex or the vaginal cuff, and then the back wall of the vagina, which is also the front wall of the rectum. And one can have any part of the vagina or more than one part of the vagina or all 3 parts of the vagina coming down. And depending on which compartment and how much determines what type of surgery they were going to have if they elected to have surgery.
And if you use a pessary, say you start using it early, does it prevent things from worsening?
Quite possibly, yes, although the data is not great on that. We do know that women who wear a pessary for a while and then they take that pessary out will say, oh, my prolapse isn't as bad anymore. It kind of stayed up. And then within a few weeks, they're like, oh no, it fell back down again. So it's not going to reverse the damage that's already been done. But yes, some people will call it a bra for the vagina. We think that it may prevent things from falling down further. We don't have great science on that, however.
And if things are falling out, is there a point at which it's dangerous? You have to treat prolapse if it's not painful. I think Dr. Linehan talked about maybe it can cause urinary infections, but like, so when is it just about like, I'd rather use a pessary than treat it surgically? And when is it like, you should probably do this, it's going to cause some possible like bad problems?
So when the vagina falls down, it, depending on the compartment, if it's the front wall of the vagina or the back wall of the vagina or the back wall of the bladder that's coming down, that often makes it difficult for us to empty our bladders. And when it's difficult to empty your bladder, it makes it a more hospitable place for bacteria to grow. And in general, the bladder is a dark, wet, warm place. It's a perfect haven for bacteria. And in women, we have short urethras. There's less distance for those bacteria to climb to get from the outside world where they live quite peacefully on our skin or in the vagina or on our partner's skin. And so it's just easier in women for those bacteria to get into the bladder. And then if the bladder's not emptying well because of prolapse, it makes it more difficult to flush those bacteria out and more likely to cause urinary tract infections, even repeated urinary tract infections after a patient's been appropriately treated with antibiotics. It just kind of keeps coming back and back and back. That can be minimized with any kind of treatment, either pessary or surgery. The times when it's truly a medical emergency is prolapse that's so severe and down so far that it's called incarcerated. It can't go back up again, and it can actually kink the ureters or the tubes that carry our urine from our kidneys, where our pee is made, down into our bladder, where our pee is stored. And if those tubes are bent, then it means that the urine that's made in our kidneys can't get down to our bladder, and it can cause kidney damage. That happens really rarely, less than 1% of prolapse patients. So the chances of this turning into a medical emergency are small, but the chances of it being bothersome to the patient or causing your recurrent infections, while it's not you need surgery right away, is, yeah, this should probably not go untreated.
Yeah, I mean, it sounds like it's a lot of quality of life issues, right? You get to pick what you want and what's keeping you from exercising or living your life if you don't want to be on medications or different issues like that.
Yeah. And I have patients who come to me and they say, I noticed this 3 months ago and now it's really bothersome. I'm taking the bull by the horns and I'm doing something today. I had a patient who came to me and I said, how long has this been bothering you? And she said, since 1994. And my heart kind of sinks because I know, she was in her 90s, but you're really you're never too old to have surgery. You're only too sick to have surgery. And she was a pretty healthy 90 something. Um, and she went home from the OR on the same day, and I fixed her in 2 hours. And so it's really disheartening to hear that patients are putting up with this so for so long and with such stoicism, especially when it can be treated.
Yeah, no, that's super helpful information to hear. So we're going to talk about our last myth. So if you guys have other questions, put them in the chat. We've got a little over 15 minutes left. And so this is a hot topic, which is, you know, look, estrogen is good for a lot of things, right? It's good for the heart, it's good for the brain, it's clearly good for the vagina. So, so vaginal estrogen, some people are very nervous about doing that, especially in my world, which has a lot of breast cancer patients. But is it hormone replacement therapy? Is it the same thing?
Yeah. So there are so many myths around hormone replacement therapy, and there's so much misinformation out there. It's really difficult for patients to navigate, even patients who are pretty medically savvy and good readers and researchers and all of that. So vaginal estrogen is not hormone replacement therapy. So hormone replacement therapy is relatively good sized doses of estrogen administered after menopause, during the menopausal transition or after menopause, typically with the goal of treating what we call vasomotor symptoms, which is commonly hot flashes. And if you have a uterus and you're on hormone replacement therapy, that estrogen is systemic, meaning every cell in your body sees that estrogen, including the cells in your uterus, if you have a uterus. And so you need to take progesterone along with that estrogen, either combination or separately, to prevent the estrogen from causing abnormal growth inside the uterus and increased risk of uterus cancer. Hormone replacement therapy, if you've had a hysterectomy, can be just estrogen. But again, every cell in your body sees that estrogen. And it's good for some things like our bones, and it's not good for other things like blood clot and stroke and cardiovascular disease, and certain cancers. So typically the party line, which I agree with, the American College of OBGYNs says, is that hormone replacement therapy is to be used during the menopausal transition or shortly thereafter, in the smallest dose necessary for the shortest time necessary to control those symptoms. And I will prescribe hormone replacement therapy because some people just have a miserable, miserable time going through menopause. And there's really nothing like estrogen to help those symptoms. But I try to not have patients on hormone replacement therapy indefinitely because of the risks. Vaginal estrogen is administered either as a cream, a suppository, or a ring. It is just estrogen, and it is locally acting. So it is not seen by every cell in your body. It's only seen by essentially the skin cells of the vagina. And it does not have the risks of hormone replacement therapy, and I will give it to women forever. I will give it to women in their 70s, 80s, and 90s. And it can be helpful at treating vaginal dryness and at minimizing recurrent urinary tract infections and making sex more comfortable if patients are sexually active. And I liken it often to steroids. So I have eczema. If I put steroid cream on my eczema, that is not the same kind of exposure to steroids as Lance Armstrong had, right? So yes, is it a steroid? Yes, but it's a topical, locally acting steroid. It's not going to help me win the Tour de France. Vaginal estrogen is locally acting. It's not going to make my bones any stronger, but it's also not going to increase my risk of blood clot or stroke or cardiovascular disease. So I feel very, very comfortable with patients being on vaginal estrogen. And then it's just a question of what formulation is best for them.
Yeah, I mean, I think, it's interesting there, as you said, there's certain things that estrogen is really good for and certain things that it's you know, can have a bad effect. And I think that's really the benefit of having a healthcare team, and especially having a primary care doctor who kind of oversees all of the things that we're looking at, right? Like maybe you have a cardiologist worried about your heart health, and maybe you've had breast cancer or breast cancer risk, and then maybe you've got some pain during sex. And so like, how do you balance all of those things? And what is the most common reason why you're prescribing vaginal estrogen? Yeah, I mean, like, what are the most common things that people come to you for, and do they get referred to you, or have they, like, how does that happen?
So really it's three things, and they're all very common. One is vaginal dryness. So patients will just say, it's uncomfortable, it feels scratchy, it just doesn't feel comfortable. That's one. Dryness that makes sex uncomfortable is number two. And then number three is recurrent urinary tract infections in women who have gone through menopause. I will sometimes prescribe vaginal estrogen in women before menopause if they're really complaining of vaginal dryness, or if they're lactating, because breastfeeding is a low estrogen state. And so they can have a lot of the same symptoms, vaginal symptoms, that postmenopausal women can have. But typically, vaginal estrogen is used in women after menopause. To answer Kathy's question in the chat, yes, if you have a contraindication to systemic estrogen, like blood clot, it is still okay to have vaginal estrogen because it doesn't increase your circulating blood level of estrogen. I will often, in patients who are concerned, have a conversation with their hematologist, oncologist, or their breast surgeon to say, hey, this patient's really likely to benefit from vaginal estrogen, wanted to get the green light from you before I prescribe it. And that will give patients with particular medical history where they shouldn't have systemic estrogen more peace of mind at using vaginal estrogen.
And when you talk about vaginal dryness, is that just itchy? What is that?
Sometimes it's itchy. Sometimes my patients will say, my vagina feels like sandpaper. Sometimes my patients will say it feels uncomfortable to sit because I feel like there's been a tampon in there for too long, even though, you know, that kind of feeling of having something there. Patients are usually pretty consistent about saying it feels dry, the same way that dry skin feels dry, or dry eyes feels dry, or dry mouth feels dry. They say it feels dry. It's a part of the body that's accustomed to a certain amount of lubrication that then after menopause isn't there.
I have two questions. One is, how do patients get to you? Are they usually, they've seen their primary care, or sometimes they just call you without having their primary care doctor refer them to you? And then the other question is, if you're having pain with sex or vaginal dryness and you start the vaginal estrogen, how long does that take to make things better?
Yeah, so I get patients from all over the place. I get patients who find me through their insurance. I get patients who find me through their family members or their girlfriends or their book clubs. I have patients who find me through their primary care physicians, their urologists, their gynecologists, their rheumatologists, their kind of, you name it, their general surgeons, whomever the patient is comfortable admitting the problem to. If the person who has received the admission knows that I exist, that's how they get to me. So any number of different ways. I think patients are getting savvier and more resourceful, and are able to kind of find me on their own, a surprising amount. But we still have to get the word out that this exists. And then your second question was how long vaginal estrogen takes to work. That's variable. Because it's a topical thing, I usually say to give it 2 to 3 months of using it 2 to 3 times a week. Typically, I have patients use vaginal estrogen at night before bed, because if it's a cream or a suppository, then we don't want it to fall out or wind up mostly on their underwear and not as much where it needs to be. It does come in a ring formulation where it goes in and the ring stays in there for 3 months, and it lets out a little bit each day so that patients don't have to think about it and they don't feel it and it's not messy. That can be less likely to be covered by insurance, unfortunately. But I usually have patients give it 2 to 3 months. There is an oral medication which is FDA approved for vaginal dryness called ospemifene or Osphena. It was FDA approved in 2014, I want to say, so it's been around for a while. It's not any better than vaginal estrogen, but for my patients who really don't like the E word, I will sometimes use that instead.
So it's not estrogen and it's not systemic, or?
It is not estrogen. It is systemic, but it is FDA approved specifically for vaginal dryness. And it's a SERM, so it's a selective estrogen reuptake modulator. It's an alternative. As I said, it's not really any better, but it's an alternative that's approved by the FDA.
That's awesome. Really interesting information. And at the Women's Health and Wellness Institute, we're looking at bringing in the pelvic floor physical therapy, which I know is, it's a difficult thing to find in the community. And we haven't had it at St. John's. And, both for prepartum, postpartum, post-surgical. Which of your patients do you prescribe pelvic floor physical therapy for, post-surgical, and then are there some that you are doing as a preventative?
Yeah, so I really would absolutely support having a pelvic floor physical therapist within the St. John's community. With the passage of the ACA, which is commonly known as Obamacare, physical therapy has to be covered by insurance. And so because pelvic floor physical therapy is part of physical therapy, it has to be covered by insurance. But that doesn't mean that any physical therapist is required to accept any insurance. And so trying to match the patient and the insurance and the physical therapist when there aren't enough pelvic floor trained physical therapists can be tough. So being able to have somebody who, if I know that they can see me, then they can see this physical therapist would really be a benefit to people. Pelvic floor physical therapy, I commonly use it for patients who have urinary leakage, either with coughing, laughing, sneezing, activity-related leakage, or with urgency-related leakage. Sometimes I'll use it for patients who have difficulty controlling their anal sphincter and have fecal incontinence. I will often use it for patients who have what we call a tight pelvic floor, and they'll have pelvic pain or they'll have pain with sex. Sometimes there are other indications, but those are sort of the most common. I use it both for people who are too loose and they need to know how to use those muscles and tighten them, and other patients who have been carrying their tightness in their pelvic muscles and they need to know how to relax them. So they do both of those.
That's great. Okay, so 2 questions. We have 4 minutes left. Let's see if we can do these. So there's one hand up, so I'm going to get to that in a second. The first one we're going to do is, what about intrarosa?
So intrarosa is relatively couple years, 3 years, 4 years new. It is like vaginal estrogen. I don't know that it is vaginal estrogen. I don't use it commonly, but it is FDA approved. It's not voodoo. It doesn't have significant side effects. I think it's actually intravaginal DHEA, if I'm not mistaken. I would say there isn't a lot of harm in trying it. It is often more costly than vaginal estrogen, and I don't know that there's any evidence saying that it's any better. So I wouldn't be worried if you're using it, but I rarely recommend it.
Okay, excellent. Tracy, you had your hand up. Are you still there? Do you have a question? She lowered her hand. Well,
Maybe I answered her question.
you might have, but
We
there
have
is
a tendency to read each other's minds.
from Carol, who said this has been another terrific session, and I would totally agree with that. I think a lot of really good. Oh wait, we have Tracy here. We have 3 minutes. I would agree with that. I think there was tremendous, great information, really helpful and basic. Tracy, if you want to ask your question, you can. We have 2 minutes left before Dr. Cadish leaves us.
No, I was just gonna weigh in on the pelvic floor physical therapy, but she mentioned the back end also. So we just wanted to make sure that that what goes with the front end sometimes happens in the back end, and Dr. Cadish and I work together. But I'm really happy to hear that we may have access to pelvic floor physical therapy, which we do in the community, and we can always
just need to
put
have
some affiliated with St. John. So that's great.
Dr. Child is my partner in crime, and we'll joke often that I'm the first 2 holes and she's the 3rd hole. So
excuse me.
I know if you turn them upside down, you're the top hole, but
That's right.
So there's a question: how do we get in contact with you, Dr. Cadish? I will put Dr. Cadish's contact information on the Facebook page for the Women's Health and Wellness Institute. But why don't you just tell everybody quickly before you sign off?
Yep.
And
So
I'm just going to say one more time, we are so grateful for your candor and your ability to explain things in very simple ways. It was really helpful.
Thank you. Well, it's been a pleasure to be here. I am in the 2001 Santa Monica Boulevard building, which, as many of you know, is the building with a terrible parking lot behind it, on the northeast corner of 20th and Santa Monica Boulevard, just half a block west of the hospital. And I'm on the 6th floor in Suite 680 West. And our phone number is 310-829-8272.
And I'll put that on the Facebook page. And next week we have Dr. Sherry Yafai, who will be talking about marijuana, CBD, THC, and how to address multiple issues that affect women in a great way. So we look forward to that. Dr. Cadish, thank you, and hope to see you all next week.
Thank you for having me.
Bye-bye.
Bye.